Good afternoon and welcome to the Maine Health Management Coalition's webinar on setting a culture for innovation. We're very excited and grateful today to be joined by Dr. Siobhan Mehta, who will be speaking on this topic. My name is Marie Stuckey. I'm the Member Relations Specialist here at the Coalition, and I'm going to just go through a brief overview of what the Coalition does and some upcoming events for the benefit of both non-Coalition members and some of our members so they know to keep an eye on upcoming events. So just a little background on the Coalition. We're basically a multi-stakeholder collaborative that's led by purchasers to improve the value of healthcare in the state and maximize it for all our members and all the citizens of the state. We have over 70 members made up of the groups you see on the left there, consumer organizations, purchasers, health plans, brokers, benefit consultants, providers, and affiliates. And our vision is really just to lead the country in population health status, patient care experience, and reasonably priced per capita healthcare expenditures so that we have a favorable business climate for job growth and a strong economy. And the ways we accomplish this work is through 5 key initiatives, the foundation of which is our data department, which has the state's all-payer benefit claims database, where we can analyze healthcare spend for our members and do some benchmarking. We also provide transparency and public reporting on metrics such as outcomes, safety, patient experience, on a variety of healthcare services on our consumer website, Get Better Maine. Consumer engagement and employee engagement is an important aspect of the work we do, providing resources to our members that they can share with their employees, whether it's a programmatic offering where they can incentivize wellness or other resources to help educate them about ways to take care of their own health. We work on benefit design and have work groups that are creating a new value-based insurance design in collaboration with all the health plans in the state that will reward providers on outcomes instead of the volume of care that they deliver. And finally, we have a payment reform group that works to provide alternative payment arrangements and explore those arrangements with providers and hospital systems in the state. So some of the opportunities that come with membership include networking, learning, and influencing healthcare reform in the state. We do that through different work groups and committees where our members are able to vote on healthcare reform changes. We have different types of other opportunities to learn from each other and network and collaborate, such as our provider-employer roundtable events or CEO summits. And what you should note immediately if you're listening and haven't registered yet is registration is open for our large annual symposium, which is taking place on November 18th in Portland. We are co-hosting it with the Maine Medical Association and have a fantastic lineup of speakers and breakout sessions that you won't want to miss. Some other benefits of membership and opportunities include our newsletters, our value-based insurance design training, webcasts that are free to members such as this, evidence-based policy training for policymakers, different pilot programs that our employer members can use with their employee populations, and discounts that are specific just for members on conferences, products, and services. This slide is just showing you a little bit more information about that great upcoming symposium I was mentioning to you. So if you want some more information about it, please feel free to reach out to us. We would love to have as many people there to network and learn as possible. This slide is showing you a list of our members, which is also available on our website. So you can get a little bit better idea about what our membership looks like. And here's some of the logos of our great, valuable members who are contributing to healthcare value in the state. Other benefits of membership include learning some best practices for workplace wellness, collaborating with other businesses and making valuable connections, getting insight from our data team on their analytics for particular healthcare spend. There's opportunities to train leadership and staff through educational events and learn about high quality, reasonably priced healthcare related services, brand your organization, and again, voting rights, discounted fees. So one thing we're really excited about is that based on Leapfrog, which is an organization that rates safety in hospitals, Maine came out very strong, and we've been able to save our members over $7.6 million because of great safety outcomes. So without any further delay, I would certainly, again, like to thank Dr. Mehta for participating and sharing his knowledge with us today. He is a gastroenterologist and the Director of Operations at the Penn Medicine Center for Healthcare Innovation. He leads a multidisciplinary team of designers, managers, and engineers to develop, test, and implement new healthcare delivery interventions across Penn's health system. Some current projects at the center focus on connecting with patients outside of traditional venues and managing the health of populations. Siobhan also conducts health services research looking at how healthcare systems can leverage behavioral economics, design thinking, and information technology to improve population health through medication adherence and cancer screening. He is an assistant professor of medicine at the Perelman School of Medicine, senior fellow at the Leonard Davis Institute of Health Economics, and affiliated faculty at the Center for Health Incentives and Behavioral Economics, all at the University of Pennsylvania. Siobhan received his undergraduate degree in economics at Yale University and his medical and business degrees at the University of Pennsylvania. And so we will now be switching the slide deck over to Dr. Mehta so he can do his presentation for you. And thank you so much, Dr. Mehta.
Well, thank you, Marie, so much for the kind introduction. I'm really pleased to be speaking today to such a esteemed group of individuals in this coalition. I've had a chance to read about the work of the coalition in the state of Maine, and I'm really impressed with the collaboration from different stakeholders across the entire state, and it really seems like this could be a model for other states in terms of how to achieve population health goals. So I'm going to talk a little bit about my experience over the course of the past few years through our Innovation Center across our institution. And first, I'm going to give a little bit of context about our organization. I'm going to talk about one of our first initiatives, an innovation tournament. I'll talk about the formation of our Innovation Center, a little bit about methodology, and then just about some portfolio and goals of our organization. So just to give you an introduction, so Penn Medicine is a large integrated academic medical center in the Philadelphia area. It encompasses both the Perelman School of Medicine, which is the first medical school in the country. So we've actually just celebrated our 250th anniversary this year, and also the University of Pennsylvania Health System, which is a healthcare delivery system that includes 5 acute care hospitals, over 2,800 physicians, 2.8 million annual outpatient visits, and approximately $5.9 billion in operating revenue. We have a tripartite mission as an academic medical center to deliver high-quality care, to educate trainees in all our different schools in healthcare, and to provide thought leadership through research to not only advance clinical care at our institution, but to provide learnings to other institutions across the country. And about 3 years ago, our organization was faced with a lot of the same challenges that every healthcare institution is faced with as a result of the Affordable Care Act, the continued rising cost of care, but also the transformation in terms of digital health and information technology. This is something that had gone from a few people using it decades ago to technology basically being involved in every aspect of our life. So as a response to this, our executive leadership felt that that while we've done well in the traditional model, the reactive visit-based model that's really a result of the fee-for-service model, we needed to think a little bit differently about how we can react to these changes in healthcare that are happening. And we need to do it in a measured approach. So part of the initial goal was to think about how we can leverage resources from across our university. So our health system is technically owned by the university, but operates as a large organization. So how could we take advantage of a lot of the resources we have across our university, including a business school, nursing school, medical school, and engineering school? So one of our first initiatives was an innovation tournament. And this was for a couple of reasons. One is that we wanted to really get a finger on the pulse of what the frontline workers were thinking about. This is something that we know is important to innovation in a lot of different spheres. But what we felt that the frontline workers, nurses, staff, managers, physicians, probably had the best perspective on where we're doing well and where there's opportunities for improvement. The second reason that we decided to do an innovation tournament is that we happen to have one of the experts in this field who actually wrote a book about innovation tournaments at the business school right across the street from us. So we were able to take advantage of his experiences. And while he had, and his name is Christian Cherwish, while he had run a lot of these innovation tournaments in smaller settings across the country, it had never really been done in such a large institution like this. So we formed a work group of a lot of different leaders from across the organization. We came up with an initial area of focus, which is to improve the patient experience at Penn Medicine, which is a pretty broad goal, mainly because we didn't really know exactly what types of ideas would come in. So a lot of this was really a learning tool. And also because patient experience and patient care is something that touches upon everybody across the organization. So we felt that this was something that everybody can associate with, whether from their perspective as a staff or a faculty member at the institution, or based on their experiences as a patient. And we initially had some goals, which was to get something like 500 ideas and to see how implementable they would be. And we actually far exceeded these goals. We actually ended up having about 1,739 ideas submitted, which far exceeded our expectations. About 5,000 of our staff actually engaged in the innovation tournament in some way, whether through submitting ideas or through rating other people's ideas. So we actually had a website where we crowdsourced the rating of these ideas on sort of similar to what you would do on Yelp, let's say, on a scale of 1 star to 5 stars. So that helped us to winnow down all the ideas to 200 ideas. So those individuals were invited to a live session. So we had 5 live sessions that we facilitated through which people could pitch their ideas and then vote on different ideas. So it was really like a tournament-like format, where similar to something like March Madness or American Idol. So people got really excited about that sort of gamification aspect of it. It also allowed different people to collaborate with each other. So we had people from different sites and different positions and different backgrounds collaborating together, because then the top ideas would be voted down and the people would join different teams. And so after that piece, the top 10 ideas actually were pitched at a large presentation to senior executives, and they selected a couple of those ideas. And you can see here what some of the ideas were. And we learned a lot from this experience. I think it was in some ways not just a way to advance interesting ideas forward, but really just to learn a little bit more about our organization, about different interests and needs. And I think we learned a couple of things. One is that these types of tournaments are a fantastic way of engaging a large population. People were so excited to participate. This was often the first time that they felt that their voice could be heard, and they were able to interact with different people, and it was really a fun format that I think everyone really enjoyed. And we also learned that we got some interesting ideas out of it, and in fact, some of these ideas moved forward in ways that did not even involve the innovation tournament. So we're still hearing about people hearing about ideas or mentioning ideas and actually advancing those on their own. The other thing we learned, which is a limitation of this type of format, which is that once you have these ideas, that's just one step in the process. So taking these ideas, especially from people that are frontline workers that may not have the time or the experience in advancing these ideas to action, we had to figure out a way to think about, how to develop methodologies and infrastructure through which we could help people with really interesting ideas and promising ideas to actually translate those ideas to action. Because the ultimate goal from our perspective in terms of innovation is not just coming up with new ideas and generating new ideas, but actually translating those to action in a way that generates value. So as a result of that, that really spawned the formation of our Innovation Center, because I think we realized that we needed some type of resource or mechanism through which we could have a group of people that are not let's say, restricted by routine operations. Most people have to provide clinical care or make sure that we deliver care to our large patient population, but having a group of people that were strictly focused on these types of methods of innovation and taking these ideas to action and to work in really a facilitated way. So our goal was not to have innovation be centralized, but really for our team to really facilitate innovation across the organization. So we have a mission, which is to facilitate the rapid, disciplined development, testing, and implementation of new strategies to reimagine healthcare delivery for better value and patient outcomes. And we also have a team that we've brought in. We started off with just a couple of people, and now we actually have full-time staff of about 15 individuals, in addition to some other folks that we collaborate with pretty closely. And this team, by design, was to bring in people with a lot of different backgrounds. Many of these people did not have a traditional background in healthcare. Some of these people did have backgrounds in healthcare. Some of them include physicians, practice managers, experts in experience design, experts in information technology, marketing, business development, things like that. So, and that's one of our our mantras of the organization, which is how can we, in healthcare, where we've been entrenched in a lot of these ideas, seek out ideas from elsewhere, but also make sure that those ideas aren't so far removed from routine operations that there is an opportunity to translate those. So as we brought along this team, we tried to think about how we can leverage different methodologies and ideas from elsewhere. So we met with a lot of people. We met with other innovation centers in healthcare and outside of healthcare. And we found that there are some methods out there that are sort of considered best practice in terms of whether it's design thinking. So we learned from organizations like IDEO and the Stanford D School, which is really a method for applying design principles to actually generate and think about new ideas. Behavioral economics is another area that we have some expertise in our organization, so we've sought out expertise from there, and also from the startup world. So startups, by definition, are organizations under extreme uncertainty. So they have really an imperative to test and validate certain assumptions pretty quickly. And in our healthcare environment, where we're trying to test out these new approaches that may or may not pan out, we felt a similar imperative, which is, how can we test these things and really validate key assumptions about ideas without making very large investments in things that may not pan out. And so as a result of that, we kind of formulated our approach to innovation, and this is just a pretty rudimentary rubric that I think we use. It's a nice learning tool, and it's a nice conversation piece. It doesn't describe the entire process, and I think it looks like it's more of a linear process when it's really something that is more iterative. So it doesn't mean that you have to start off on the left side and move to the right side. In some cases, you could do the rapid experimentation as a learning tool. So just to go through the sort of the 4 phases, and we call this the double diamond. The first phase is to discover, and that's to gain deep insight into some of the issues, the problems, the structure, the challenges of that particular solution or that problem. So that includes things like contextual inquiry, observations, traditional methods of focus groups, surveys, looking to the literature, doing some literature review, some secondary data analysis. So how can we understand a little bit more about the problem and perhaps uncover things that have not been seen before? The second stage is to really be very sharp in our definition of the problem. So if we can't define the problem and an outcome that could be improved upon, it's very hard to think about different solutions. It's hard to be disciplined about it. So it's really important to define the problem, but also define the right problem. And often, what you may think is a problem may be just one step in a larger issue. The third step is to diverge and to identify a lot of different solutions, sometimes seeking out solutions from elsewhere, seeking out analogies. Co-creation is really important, making sure that the key stakeholders are involved, and that includes frontline workers and also patients. If patients are really what our organization is about, we should include them in the decision-making and in the ideation. And the final stage is to validate or to experiment on these solutions. So how can we take some of these ideas and do some rapid experimentation to learn a lot more about both the problem and the solution? So in the next few slides, I'll go through a little bit and sort of gloss over a little bit just to give you a flavor of what are some of the types of things we're doing in the different stages. So in terms of contextual inquiry or gaining insight, we do those traditional methods, but some of the things we've done is actually go out to patients' homes and do some observation there, talk to them about what's going on in their life, because if we think about how we're trying to achieve certain outcomes and improve outcomes, some of that pertains to things that happen when they see the doctor or come into the clinic, but most of patients' outcomes relate to things that happen in the thousands of hours when they're not seeing us. So if we really want to figure that out, we have to understand what the context is in their life. So for a couple of projects, one focused on post-heart attack patients, and the other one focused on congestive heart failure patients. We actually went out to patients' homes here in the community in Philadelphia, and we talked to patients that had recently discharged from the hospital. And I think we learned a lot of interesting things. I think we learned that the information we give is incredibly disorganized and probably information overload. So you can see there on the left that patients keep information in bags, and they don't throw away anything. So they still have information from a hernia repair 4 years ago. You can see how they keep their medications and how, I as a gastroenterologist will prescribe one medication, but I often don't think about the fact that they're taking 10 other medications. So you can see here that they have varying sized pill bottles, and the instructions are not sufficient to provide them with the information they need. And on the right side, you can actually see workarounds. So these are things that patients have created for themselves to basically sift through a lot of the data. And these are actually really useful as we identify solutions, because patients are often the best way to find out solutions. So sometimes these workarounds actually tell us a lot about how we can come up with solutions. So you can see here on the right, on the bottom right, that the way that we describe medications is not sufficient. So they use large lettering, they use words that they can understand, they describe it in much simpler terms than a lot of the medical jargon that they hear about. So the second phase is identifying a problem. And so we get sought out for solutions all the time. So, one of the, the benefits or the advantages of an innovation center is that we've done good work, and people from our executive suite are seeing the value in what we're doing. So they often bring us into a lot of different urgent problems. And we call these executive level requests. So about a year and a half ago, there was a big issue in terms of oncology length of stay, and this was for our liquid oncology service. So we're a regional referral center for patients with leukemia and lymphoma, and these are really urgent issues. So once they get diagnosed with this, they need to typically be admitted to the hospital, get rounds of chemotherapy, be monitored for a variety of different conditions, and then get discharged home. And what they're finding is that there is a big backlog in terms of whether we could even accept new patients for these types of elective or semi-elective admissions. And so the way that this problem or this project was initially phrased was that it was about length of stay, how we can discharge patients sooner so we can open up beds. And in doing some observation and talking to some of the key stakeholders, we actually learned that the problem and the solution is really not about length of stay. It's about how we can get patients from their diagnosis to chemotherapy as soon as possible. And as soon as we changed and shifted that framework, it offered a lot more solutions. So instead of just focusing on ways to get people out of the hospital sooner, we focused on ways to get people into care sooner, how we could triage them, and potentially how we can provide some of the initial phases of treatment before they come into the hospital, whether it's checking certain labs, whether it's getting certain types of PICC lines or things like that to get their chemotherapy. So this really changed the paradigm through which the oncology service is thinking about this, and we're still hearing about this type of different problem definition. And the last phase, which encompasses probably the third and the fourth steps of the process, is really about rapid experimentation. So if we want to identify a number of solutions, we also have to think about ways to validate or test these solutions quickly. And the traditional model of running a pilot, scaling that pilot, typically takes months to years. And so what we want to do is really try to think about how we can test different solutions or assumptions in action, because you could brainstorm things all the time. We spend a lot of time in rooms talking about different solutions and how solutions can go in different directions, but the only way to really know if something works or not and what some of the challenges are is to actually employ that in practice. So we actually use something called a fake backend or a minimum viable product. So this is something that startups use all the time to really see if there's the right demand for different solutions before actually investing lots of effort and resources in developing those solutions. So one of our colleagues in the orthopedic practice, one of the practice managers there, was always thinking about whether to offer same-day scheduling or same-day appointments for orthopedic surgery. So orthopedic surgery is an area that is very consumer-centric in that it's not necessarily reliant on patient referrals. It's more reliant on patients actually coming to different centers or different institutions to get care. So his basic question was, if we offered same-day appointments, would that open up the floodgates? Would we be able to deal with the demand? And would we actually get the right type of patients, so patients that really would benefit from orthopedic care as opposed to seeing a primary care doc or a family medicine physician? And so he basically ran this fake back end for about a week. So they had the ability to change the website. They offered same-day appointments on their website, and they actually had a phone number to call. But instead of going through the call center, the phone number actually went straight to his cell phone. So he was considered the fake back end, and he was able to manage these requests and actually see what kind of requests there were, and because he was closer to a lot of the action and closer to a lot of the physicians. And what they found is that there are 45 total inquiries, 36 appointments were scheduled. Many times patients didn't actually need same-day appointments. It was just a marker for being able to be seen quickly. Often when we gave them the appointments for the same day, they wanted to be seen in a couple of days. It resulted in surgeries in that people actually did need to be seen by an orthopedic surgeon, and 50% of those patients were actually new to the institution. So it actually brought in new patients that we didn't have access to before. And so when we think about rapid experimentation, we do want to test these things rapidly, but we also want to be measured and hypothesis-driven about it. So this is something that we learned from the scientific method, or from a lot of the things we do in the research world, which is that good improvement or innovation work also should have some rigor. You need to have a hypothesis, define a metric for success, make a prediction, actually implement something, and see if it had impact or not. So this is something that we really preach, to really be measured about things, because otherwise you could be testing out a lot of different things, but if you don't have any criteria ahead of time to see if you should move it forward, if you should stop, or if you should pivot, it's really hard to figure out how to move forward next with these potential interventions. So moving on, so we developed this methodology. We worked on a number of projects. I think we got a lot of good feedback, but I think we were finding that we were probably spread a little bit too thin, because it's such a large institution. There was such a large appetite for these types of methods, for testing out new approaches, for experimenting on these things, which was a great thing for our center and for our institution. But we needed to think a little bit more critically about how we select projects. So we wanted to really think about a portfolio of projects, because we're funded by the health system, there was an imperative to deal with current business issues. But because we're an innovation center, we actually have to prepare for the future and prepare ourselves for not just the current issues or the current problems, but what's going to happen 5, 10 years down the road. We also wanted to really balance things that come from the top so meaning executive level requests with things that come from frontline workers. We certainly have to answer to the senior executives because they have a good sense of the priorities of the organization, but we also want to make sure that we're giving different people that have interesting ideas the opportunity to advance those ideas. So we basically have 4 ways through which we work on projects. On the top left are executive level requests, so these are things that come from the executive suite. Typically things that they've tried working on for many years and have had trouble with for a variety of different reasons, and they're looking for a different or new perspective. On the top right is our employee health population, so that's one that we're self-insured for. So we have about 27,000 covered lives that we have full financial and health risk for. We want to improve the value of care. We also want to make sure that our employees are happy and want to work at Penn Medicine. So that's really our learning lab for thinking about population health. On the bottom left is training and partnerships. So how can we work with the large ecosystem across the health system and the university, and even in the city? And on the bottom right is our innovation grant program, and that's really the evolution of the innovation tournament. How can we work with frontline workers and figure out ways to work with them in a structured way? And even that program has evolved, and I'll talk about that in a couple of slides. So in terms of employee health, as I mentioned, this is our learning lab for population health. We are involved in some bundle payments and some accountable care organizations, but I think the big challenge with a lot of those is that some of the data that we're getting is often not in real time. There's some degree of shared savings, so we don't necessarily have full financial risk, and it's often a small portion of populations. So we felt pretty strongly that this is a great population we can work with, and think about a variety of different ways to both improve the health of this population by reducing the burden of disease, but also improving the value of care. How can we think about ways to bend the cost curve? So we basically have come up with a couple of different projects, and this is certainly not all-encompassing, nor the only projects that we want to work on for employee health, but we felt that these are things that are important enough, things that could provide learnings for the broader employee health population, but also areas that could provide learnings for other risk-based structures. So if we can learn something in our employee health population, we can actually think about translating that to our overall patient population, and specifically with a lot of these new accountable care mechanisms. So a couple of the areas we focus on for reducing the burden of diseases, one is population-based hypertension management. It's something that affects a large portion of the population. 50% of those are not managed appropriately or not achieving the right blood pressure goals, and that could be for a variety of different reasons. So we try to think about, are there ways to do this more efficiently that does not burden the primary care physician or burden physicians? Another one is population-based colorectal cancer screening. Colon cancer is the second leading cause of cancer death in this country. There are very effective ways of screening and managing these patients and finding early stages of the disease, yet what we found in our employee population, which was interesting, was that our screening rates are no different than the national average. So national average is something like 60 to 65%, and in our employee population, which is actually 60% nurses, many physicians, many people with clinical backgrounds that actually have access to care and insurance, yet they're still not getting screened. So how can we actually take that intent to get screened or the knowledge and actually drive that to action? So we've run a bunch of different experiments there. And then the second category is improving the value of care. We've done some things with benefit design, which is a nice advantage of our employee health population. So how can we think about things like advanced imaging, specialty pharma, things where there's a pretty steep trajectory in terms of rising costs, but also thinking about how we can improve the value, making sure that we still have good outcomes. Employee access to primary care was a big issue for our own employee population because many of them would just see specialists, many of them would not see primary care docs, and about a quarter of them 3 years ago would see primary care docs outside of Penn. So what can we do to leverage existing primary care capacity to make it very, very easy for them to get access to primary care, but potentially to get access in ways that don't involve actual visits? Can they leverage telephone, telemedicine, things like that? And that links into our last project in improving the value of care, which is reducing avoidable ED visits. So we're finding that 50% of our employees go to the emergency department at some point in time, and many of them for conditions that may not require that high degree of acuity. So can we think about ways to provide care on-site, text messaging, chat, telemedicine, things that fit into the employees' lives? So we're actually we're undergoing a couple of pilots in that realm right now. And the next program is now called our Innovation Accelerator Program. So it first started off with the Innovation Tournament, which was generating interesting ideas and engaging an employee population. Then for the past couple of years, we actually called it the Innovation Grants Program. And I think what we learned from that is that money is actually not the limiting factor for these projects. Typically, it's the knowledge and the time and the ability for these frontline staff to actually work on these projects. So what we do is we actually provide them with resources for experimentation. We provide some teaching and training on methods of innovation and improvement. And only if they demonstrate early outcomes through actual pilots and interventions will we provide follow-up funding. So our new approach to this program is through more of a phased approach, and that's something similar to the venture capital model, where venture capitalists will make small seed investments in projects to allow them to validate key assumptions, and then if they demonstrate evidence, they can actually translate those ideas and give them further funding. So that's our new approach, and we're actually in the process of selecting about 8 projects for the new round of the Innovation Accelerator Program, and they come from lots of different departments and different backgrounds and different entities. And the last area is through teaching and training. So we're pretty fortunate as an institution to be in a large health system associated with a large university that has many different schools and students and trainees, and also part of a large city that has different schools and people from across the region that we can collaborate with. So in addition to us driving projects, we also see ourselves as a tool for enabling a culture of innovation. And that means working with all sorts of students and trainees, whether they're Wharton MBA students or medical students that are interested in entrepreneurship, or through our existing organizational development roles across the health system, or even in other schools and universities. So the University of the Arts has a master's in industrial design that really focuses on design thinking. And we've managed to work with a lot of these students. And I think what works well is to basically leverage existing infrastructure. So many of them have independent studies, or they have internship programs. So if we can link in with those programs, then I think we can be a little bit more successful, as opposed to owning all of the teaching and training. So how could we collaborate with different programs across the institution? I think we found a lot of success there. And finally, and this is something that came out of our last retreat. So we've hired a lot of staff, and I think the staff have really provided a lot of value, and many people across the organization have been very pleased with the projects we've done. We've worked on a number of projects in different portfolio areas, and I think we've been pretty successful there. But I think we also had to think a little bit more strategically about how do we define success in the long run for our center? What are some outcomes and metrics that could really guide our choice of projects? So whether to choose project A or project B, but also how much we should participate in projects. So when do we know when a project is complete? When do we know when we make the right handoff to the operational leader? How do we think about scaling projects? So as a result of that, we basically came up with 5 5-year goals, and each of them are tied to specific outcomes and metrics that I won't go into. But it gives us a flavor of how we can select different types of projects and have a portfolio for our center. So the first one is making people healthier. How can we reduce the burden of disease and improve population health metrics? So the areas of hypertension, colorectal cancer screening, and actually tobacco is another one that we've looked at as well. Reducing the cost of healthcare. How can we think about ways to really bend the cost curve and improve the value of care we provide? So that's focusing on our employee population, thinking about things like benefit design, but also avoidable ED visits and low-value services. 3 is bringing care into people's lives. I think we acknowledge that healthcare is moving from this visit-based reactive model where people have to go into hospitals and clinics to get their care to one where we can actually bring healthcare into people's lives and to context of their lives. So can we develop new approaches and programs and business models for bringing healthcare in people's lives, whether it's a teledermatology, remote monitoring for heart failure, medication adherence, checking people's blood pressure after they've been women have been admitted to the hospital for delivery and then had preeclampsia or eclampsia. So that's our third area of focus. Our fourth area is really thinking about how we can enable and accelerate innovation across our organization. So how can we make sure that we're working with lots of different departments as opposed to just the ones that are close to us in terms of geographic location? How can we make sure that some of our methods have touched upon lots of different people across our very large organization? So that's really leveraging these existing training mechanisms and thinking about how we can partner with them. And finally, as an academic medical center, we not only have a goal to improve the care of our own population, we want to really provide thought leadership and help improve clinical care everywhere. So if we find things that work here at Penn Medicine, how can we disseminate that and share that with other institutions? And this could be things like traditional research, whether it's publishing in journals and papers and things like that, but also a lot of other ways. How can we collaborate with other innovation centers and other health systems? How can we collaborate with insurance companies? You know, we work with our largest insurance company in the area, Independence Blue Cross, on a variety of different initiatives. So that concludes my talk for today. I'd really be interested in hearing if people have any questions or comments about some of the work we've been doing, and seeing if that resonates with a lot of the work that you're doing in Maine.
Thank you so much, Dr. Medhouse. Very much appreciated. I will let our attendees know that at the bottom of your screen there's a chat box where you can type in any questions that you have, and I'll be happy to read them to Dr. Mehta for him to respond to. Meant to mention that early on and forgot, but if you have questions that have come up in the interim, please go ahead and feel free to type them in there, and we can translate them to him so you can hear the answers. Okay, we do have somebody's asking about how innovation may be compare to quality improvement. What's similar, what's different?
So that's a big issue that we come up with all the time, because we do have a very robust performance improvement or quality improvement infrastructure across our organization. And I think that people often try to create this dichotomy between innovation and improvement. So I guess I would say that I think there's a lot that aligns and there's a lot of overlap between the two. It's important to identify a problem. It's important to test things in the real world. It's important to evaluate if that improves or not, and it's important to iterate and to think about scale. You know, we're interested in the same types of outcomes, things like the triple aim or value of healthcare. So, I don't think it's a sort of either or thing. I think it's just a matter of sometimes a different perspective. And I guess the way that we think about it here, which may be different at different places, because some places performance improvement, quality improvement also includes innovation. But the way we think about it is if you're trying to improve the existing process, if you're trying to make it more efficient, make it better, think about scaling it across the organization, or think about taking things that have worked elsewhere and implementing that here, that's probably more along the lines of performance improvement or quality improvement. If you're thinking about developing new approaches or things that have not been tested or developed before, then I think that's a little bit more along the lines of our innovation center and innovation. Because I think our methods of divergence and deep contextual inquiry and design thinking are probably more in line with those types of approaches, things that don't exist in the real world right now. So how can you take these ideas that are abstract and make those more concrete? Now, we also get involved sometimes when there are certain projects that have been tried and have had limited success. So sometimes we come in to participate and to offer a fresh lens or a fresh perspective. And many of those people could call in improvement projects. So I guess my short answer is that I think there's substantial overlap between the two, and I think it's really important for any innovation groups and improvement groups to really partner and work very closely with each other, because I think there's going to be more success that will be achieved that way.
Okay, thank you. We've got another question that sort of builds upon that, actually, in terms of responding to innovation. Have you experienced some resistance to the innovation efforts early on from those in charge of the system, and how was this resistance dealt with or overcome?
Yeah, and I think that we've been fortunate that we've gotten a lot of support from the executives across the institution. So our Innovation Center was actually commissioned by the CEO and the Executive Vice President. So it really did come from the top. So that was a really important aspect of our center, because it really allows us to make sure that we're aligned with them, but also gives us a little bit of buy-in across the organization. We've also received a lot of positive feedback from the frontline workers that have wanted to work with us. So I think that for the most part, in the abstract, I think that most people are really interested in working with us, and we've gotten a lot of positive reviews. Now, the challenge is anytime you're trying to change things or make things different, there often is a little bit of inertia and perhaps resistance to change. You know, as a physician, I know that we've been trained in things a very specific way, and you know, through years and years of training, and we're very passionate about the work we do. You know, that's one of the advantages of being part of an academic medical center or a nonprofit health system. Just about everybody that works here for the mission, and they're really focused on how can we make our patients better and how can we get better at our job. So, but when you often question things and question key assumptions or try to infuse different ways of thinking about things, I think sometimes there can be a resistance to that. And so that's always a challenge, I think, for any time you want to affect change across an organization, and not because of any underhanded means, but mainly because people are just used to a certain way of thinking about things, and they're very passionate about it. So in doing so, I think that the key thing is to really co-create solutions. So I think we've learned that we can't go in and force people to do something different. Our projects are not, we don't drive or lead projects necessarily. We really collaborate and facilitate projects. So if we work on a project, there has to be a clinical champion, executive champion, administrative interest in working on this, and we see it more of a partnership, because then they're coming up with the solutions and we're facilitating that. And then also when we finished our engagement on the project, it actually has a more warm handoff in order to implement that afterwards. If we drive something and then we leave, it usually won't have that excitement to move it forward.
That makes sense. Can you explain more about same-day appointment on the web portal?
Sure. So it's something that I think people talk about a lot. You know, I know the Cleveland Clinic offers that, and a number of other institutions have moved forward on that. I think our organization, because we're really a tertiary care center, and you know, there's certain physicians that just have a very, very long backlog in order to see them. And I think people come to our institution to see a specific oncologist or a transplant surgeon or certain types of physician. So I think because of that, people were initially resistant to that idea because we weren't sure if we could really deliver upon it. And it's something that I think caused a lot of anxiety for a lot of physicians because as it is, our physicians work really hard. They see lots of patients, they're doing research, they're doing teaching, they're dealing with the electronic health record, they're dealing with a lot of regulatory issues in terms of medicine. So I think there was initial resistance because they felt that this would just be another burden, and then it would be one extra patient that they would have to see after hours and try to squeeze in and try to limit, and it may actually impact the care that they provide for their other patients. So I think that there was that perception of that was a big issue, and I think that that's where this rapid experiment was really useful in kind of changing that perception. And basically since then, because of that initial key finding, they've actually scaled that to the rest of the orthopedic practice. So now orthopedics, for many of their other specialties, are offering same-day appointments. It's actually been considered a model for other departments. So as other departments think about access, if you bring somebody in sooner, it doesn't necessarily have to be that physician that sees that patient. It could be another physician or colleague. It could be a nurse practitioner, or it could be a physician's assistant. Often from the patient perspective, this is something we learned in the oncology space, there's so much anxiety from when they get the diagnosis to when they see a clinician in an institution. So that long wait period is not just a way to get more patients, but it's really a way to alleviate anxiety for patients. So can we think about other ways to see patients and do same-day appointments? It could be a telephone visit. It could be a telemedicine visit. It could be a variety of different things. So I think that's where we stand now in terms of our institution. We want to provide access, but access doesn't necessarily have to be a live visit with a specific provider within a certain time frame. We can leverage a lot of the other resources we have across the organization.
Okay, wonderful. We've got just about 5 minutes left. I'll give you one last question from one of our attendees, which is, how frequently do you organize the walk-in employee health clinic, and how much collaboration do you receive from providers for that?
So that's been an interesting project. So actually the way that it came about was that I think our occupational medicine physicians, currently they only deal with workplace-related injuries. And I think they saw from a lot of their colleagues across the country, and not just in health systems, but in lots of large employers like the Googles and the GEs and the American Expresses of the world that provide on-site care. So they saw that and basically said, can we think about doing that here at Penn? And basically as a way to do a quick experiment, instead of trying to get the budget and get the space and hire staff, we said, let's just offer that up as sort of a pop-up clinic. Let's offer it for 1 month. And let's see what happens. Let's see what kind of demand there is. Let's see if we can deal with those types of patients. Let's see if they're the right patients. Let's see if seeing those patients has other benefits. And I think what we found is that we ended up seeing about 32 patients just in a month for a small portion of the population. Most of those issues could be remediated by that staff there in the clinic. A couple of the patients said they would have gone to the emergency department for care. And we actually found that it actually potentially reduced the amount of time that patients were away from work. So it had a lot of great benefits. But I think the big challenge was really an operational one. We have 5 different hospitals, many different sites. So I'm not sure we necessarily have the capacity to have all these occupational medicine clinics offering all these appointments, especially given the space constraints. So our next iteration is to basically say, let's leverage this as a virtual on-site clinic. So instead of having to walk in and go to a specific site, let's offer this to the entire population in a way that you can get someone on the phone right away, you can communicate with them through different channels, and you can be assured that they will actually be able to deal with all the issues you have. So where we stand now is that this has been a true collaboration with a lot of different departments. So primary care for us includes our faculty practice in general medicine, our faculty practice in family medicine, and our community care practices. And this is something in the order of about 35 to 40 practices across the region. We've also collaborated with the emergency department. We've collaborated with our eAlert, which is our remote monitoring service, with our IS department. And the new iteration of that is to basically say, we'll see you very quickly and we'll manage you very quickly, and we'll do that over the phone. If you need to go to the emergency department, we'll offer you fast-track appointments to the emergency department, and we'll direct you to the emergency department that has the most capacity close to you. If you need to see a live visit, we'll get you an appointment by leveraging capacity across the entire health system as opposed to one specific practice. But potentially, and the real goal is to be able to remediate some of those situations over the phone. Can we prescribe you medications that you need? Can we get the x-rays that you need right away without having to go to that live visit? So that's where we stand now, which is that we've really iterated to a version 2 of that pilot, because I think we realized that that it has to be a little bit more distributed.
Thank you so much. I have another question, but I think I'm going to email it to you because we have another webinar that we have to prepare for. But Greatly appreciate the information and the attendees here. Thank you so much for sharing your expertise. For those who are interested in learning more about behavioral economics, we are having a breakout session at our symposium on November 18th on that topic. And if you, another way to get more information is some links that I think you had provided to me, Dr. Mehta, that I could probably share with our attendees today. Isn't that true?
Yeah, feel free to go to our website or even email me if you have any other questions or comments about some of the things that I talked about.
Wonderful. Well, again, much thanks to all. Very informative, and hope to see you at the symposium. Thanks so much for joining us.